Hi, my name is Mia Ryman, and today I'm going to be talking to you about Enterovirus, D68, and Pertussis in the pediatric population. Enterovirus D68 is considered a rarely reported disease even when compared to other lines of non-polio enteroviruses. The first case of Enterovirus D68 was in California in 1962. Internationally, the disease has been identified in Japan, China, Philippines, and Netherlands. Some of the reasons for reduced reporting is the fact that most clinicians do not think of enterovirus until all other respiratory illness etiologies have been ruled out, as well as the ability to test for enterovirus D68 is specialized and limited testing facilities are available. Even though it is considered a rare condition, outbreaks do occur. The most recent outbreak was in Canada, as well as the United States, which was considered the largest ever reported in North America. It had a total of 1,153 confirmed cases. Since this is such a rare condition, I had difficulty finding cost and burden to the community. With enterovirus, the progression of the disease and the severity of the disease can result with children and infants on mechanical ventilation, as well as possibly death. Once diagnosed, it's recommended that children stay home from school and daycare. Throughout my research, I feel as though when diagnosed with enterovirus, the cost and burden to the community will be high due to missed work from the parents as well as high medical bills from potential hospitalizations. I believe that with the increased cases, especially with an outbreak, the burden on the community would increase as well. Enterovirus D68 is an RNA-specific virus that is part of the Enterovirus genus. There are many different types of enteroviruses, but today I'm going to specifically look at human Enterovirus D68. Enterovirus D68 is part of a larger group of enteroviruses. The formation of the virus is a little different than the rest of its viral pathological family. Enterovirus D68 is actually closely related to rhinovirus due to the fact that the enterovirus D68 targets lower temperature areas, approximately 33 degrees Celsius versus 37 degrees, as well as a lower acidic area versus its counterparts, which can affect the GI tract. Enterovirus D68 attaches itself to respiratory cell membranes where the virus then penetrates the cell and begins uncoating of the viron. The viron then begins the synthesis of negative strand RNA, creating new viruses and taking over the cell. A major site for viral replication is the pharynx. From there, the virus then spreads utilizing lymph tract throughout the body to the sites where symptomology is present. So, in the case of most enterovirus D68 cases, the lungs and respiratory tracts are the destination. This form of enterovirus specifically affects children between the ages of 6 weeks and 16 years old, although the majority of cases occur at approximately 5 years old. The risk of contracting enterovirus D68 increases with newborns, hormonal or immunodeficiencies, stem cells or organ transplants, malignant diseases, patients receiving monoclonal antibodies, obesity, and asthma. The transmission of enterovirus begins between 1 day before symptoms start and up to 5 days after symptom onset. Transmission of enterovirus D68 is through droplets as well as contact. Therefore, the patient will transmit the virus through coughing, sneezing, and inadequate hand hygiene. Signs and symptoms for enterovirus D68 vary from mild to severe. Mild symptoms range from fever, rhinorrhea, sneezing, coughing, sore throat, dyspnea, wheezing, and malaise. Severe symptoms may range from respiratory distress to even neurological illness. Throughout the research, it seemed as though the symptoms for enterovirus D68 generally traveled down the respiratory tract rather than the neurological tract. The major respiratory complications found throughout the research are pneumonia and asthma exacerbations. Even though enterovirus is considered a non-polio enterovirus, it still causes a small number of neurological cases, in which cases that cause neurological symptoms are generally more severe and cause more severe symptoms. Some of the neurological symptoms can be meningitis and paralysis. Labs and diagnostic tests for enterovirus D68 start with a history and physical. These children are more likely to have history of allergies, asthma, or some form of reactive airway disease. By obtaining a full history and physical, it will be important to determine if the child has an increased risk factor for this condition. Generally, throughout the literature, the testing for enterovirus D68 occurs after the infant or child is diagnosed with a respiratory illness of unknown etiology. reverse transcriptase polymerase chain reaction, RT-PCR, is considered the gold standard for the identification of Enterovirus D68 due to its increased sensitivity along with more rapid results versus culturing. With RT-PCR, either respiratory secretions or cerebrospinal fluid is obtained and generally sent to a testing facility. Unfortunately, most laboratories do not have adequate equipment to conduct testing for Enterovirus D68, so specimens must be sent to facilities where these molecular techniques can be performed. The CDC reports that they have laboratories available for testing for non-polio enterovirus through the RT-PCR test. Information regarding who should be contacted as well as how to handle the specimen is located on the CDC website, and the hyperlink is listed below as well as on the reference page. Last, all confirmed cases of Enterovirus D68 must be reported to local or state health departments, who will then notify the Center for Disease Control's National Enterovirus Surveillance System. Unfortunately, for the prevention of Enterovirus D68, there are no vaccines available. There are no antibiotics or antivirals which will assist with the treatment of the condition. Throughout the research, I discovered that most treatment was through supportive care when it came to Enterovirus D68. In mild cases, patients may have supportive therapies such as antipyretics, increased hydration, and bulb suction. Patients with more severe cases may require oxygen, IV fluid, nebs, with bronchodilators, and possibly even intubation. Finally, it will be important as a healthcare provider to provide emotional support for both the patient and family. This condition is rare and new to the family, therefore it is essential to provide support regarding the supportive care throughout the patient's treatment. Now we are going to look at differential diagnoses regarding Enterovirus D68. My first differential diagnosis would be an asthma exacerbation. Some key symptoms to consider an asthma exacerbation would be through the assessment of the patient's respiratory workload, such as dyspnea and wheezing. I would want to complete a full health history to see if the patient has a history of asthma. If the patient does have a history of asthma, is it well controlled? Is this the same symptoms that the patient experiences with previous asthma exacerbations? Next, I would want to assess if the patient was around anything that could cause triggers to an asthma attack, such as smoke or increased physical exercise. This would be an appropriate time to rule out asthma if the patient is also experiencing symptoms such as fever, rhinorrhea, sneezing, sore throat, and malaise. The next differential diagnosis I would want to consider would be influenza. With the pediatric population, influenza can be deadly. Therefore, it would be imperative to get a rapid flu test to ensure that influenza is not the culprit. Some rule-in symptoms that would alert me to check for influenza would be the cold-like symptoms, such as fever, rhinorrhea, sneezing, coughing, sore throat, dyspnea, and malaise. I would rule out influenza if there was a negative rapid flu test. My last differential diagnosis would be Bordetella pertussis. The rule-in symptoms for pertussis would be the common cold symptoms, especially coughing. The rule-out symptoms for pertussis would be the lack of post-tussis emesis and a lack of whooping sound with inspiration. So how do we as healthcare providers promote health? It is important to prevent the spread and contraction of Enterovirus D68. Therefore, it's essential to educate all patients and family members on proper hand washing technique. This entails washing hands with soap and water for 20 seconds frequently throughout the day. Along with frequent good hand washing, parents need to be educated to work towards a decrease in the child touching their face, nose, and eyes. Since Enterovirus D68 is spread through droplets, it would be important to disinfect the child's toys, utensils, and other things to avoid the spread throughout the household. Recommendations request that children with enterovirus stay home from school or daycare, especially if the child has a fever. To ensure that the patient is well controlled with respiratory function, if the patient has asthma, it's essential to make sure that it is well controlled. Last, assess if the patient and family have been immunized with the flu vaccine. Throughout my research, I have found that the CDC has many handouts regarding enterovirus, hand washing, and other educational handouts for patients and parents. The link for the handouts are listed below as well as on the reference page. So now we're going to change gears and take a look at pertussis. Pertussis, also known as whooping cough, has had an increase in outbreaks over the past few years, even though vaccines are available. The CDC reported 15% increase in cases from 2013 to 2014. If you look at the graph on the right of the slide, you can see an increase in pertussis reporting is primarily in the infant population. The CDC also reported that across the globe there are about 16 million cases of pertussis and about 195,000 deaths per year. Throughout the research, it has been identified that there is a race disparity when it comes to the completion of the 3 vaccine set, and it may be due to economical status as well as access to health care in minority populations. The cost of pertussis ranges depending on the age of the patient. For infants, the average cost of pertussis hospitalization was $9,586. For children, it was about $4,729. And for adults and adolescents, it was about $5,683. And this is per stay. Either way, the cost of the family as well as the medical facility is high for the treatment of pertussis, especially since this condition can be prevented through vaccinations. Pertussis, also known as whooping cough, was named after the Latin term for intense cough, as well as the Chinese translation of the 100-day cough. Pertussis is caused by the bacteria Bordetella pertussis, which is a gram-negative coccobacillus that survives in respiratory secretions. This respiratory condition occurs when the pertussis bacteria attaches to respiratory epithelial cells known as the cilia. The bacteria then goes on to produce pertussin toxin that specifically targets the cells. The toxin will disrupt the function of the ciliated epithelial cells and cause paralysis. This in turn causes inflammation of the larynx, trachea, and bronchus, as well as the host loses the ability to cough up the mucus, which results in a spasmodic and episodic cough. Pertussis is set up in stages which are identified as incubation, catarrhal, paroxysmal, and convalescent phases. The incubation period of pertussis is from between 4 to 21 days. Then the disease is divided into 3 stages. The first stage is the catarrhal stage. This is the part of the disease where the upper respiratory symptoms are noted and may be confused with a cold. Some of the symptoms are runny nose, sneezing, and mild cough. The next stage of the pertussis disease is the paroxysmal stage. This is where the cough begins to worsen and begins to become spasmodic, also known as the whooping cough. This stage of the disease may last up to 10 weeks. Keep in mind that infants less than 6 months may not necessarily have a whooping cough, but have been noted to commonly have cyanosis and the posttussive emesis. The final stage of pertussis is the convalescent stage. This stage is where the cough begins to gradually improve. This stage normally occurs over 2 to 3 weeks. Transmission of pertussis occurs via droplet with coughing or sneezing. The spread of pertussis is increased with poor cold etiquette, such as not covering the cough or sneeze, as well as poor hand hygiene. The signs and symptoms of pertussis is related to age as well as the disease stage. In the first stage of the disease, the catarrhal stage, the patient will experience common cold symptoms such as runny nose, congestion, and sneezing. The patient may also experience a low fever or mild cough. As the disease progresses to the paroxysmal stage, the cough becomes more violent. The pediatric patient begins producing thick mucus that is difficult to expel. And at the end of the coughing attack, the patient will inhale with a whooping sound. It is also not uncommon for patients to vomit after the attack. Cyanosis may occur in all pediatric and infant patients, but it's key to keep in mind that some infants may only display the symptoms of cyanosis and emesis after the coughing attack. Throughout the research, the paroxysmal cough is the most classic symptom of pertussis as well as the posttussive emesis. The diagnosis of pertussis can be determined through a thorough history of symptoms as well as through laboratory tests. A sputum culture is the gold standard for testing for pertussis, but is recommended within the first 2 weeks of the cough onset. A culture is the only test with 100% reliability for the first 2 weeks. After the first 2 weeks, there is an increased risk of false negatives. The culture is obtained through a nasopharyngeal aspirate or swab. The nasal aspirate is a better choice between the two because it isolates more secretions than the swab alone. Other testing options are the polymerase chain reaction and direct fluorescent antibodies, but both carry a high rate of false negatives. Last, the serologic test, which detects pertussis antibodies, is best between weeks 2 through 8 when the antibody titer is highest, but it can be accurate until approximately 12 weeks. This test is useful in determining pertussis titers but does not distinguish antibodies created from the vaccine versus exposure of the disease. Therefore, the test is not very accurate when testing patients that have had a pertussis vaccine within the last year. So now we are looking into pertussis treatment. The treatment of pertussis starts with early identification through symptomology or the previously discussed laboratory tests. The earlier a patient begins treatment, the better the patient outcomes. As the CDC reports, the implementation of antibiotics in the late stage of pertussis will not alter the illness course. Both the early and late diagnosis of pertussis is treated with antibiotic therapy. The 4 antibiotics recommended are erythromycin, azithromycin, clarithromycin, trimethoprim, sulmethoxazole. Some key concepts regarding antibiotic therapy are erythromycin can be used in patients less than 6 months old and in patients that are intolerant of erythromycin. For infants less than 1 month old, the utilization of other antibiotics has been related to infantile hypertrophic pyloric stenosis, whereas azithromycin has not been associated with IHPS. Erythromycin is not recommended for children less than 1 month old, and trimethoprim sulfamethoxazole is not recommended for infants less than 2 months old. With the use of antibiotics, it is also recommended to treat all close contacts with antibiotics for prophylaxis of pertussis. For the treatment of pertussis, it is also essential that droplet precautions are implemented immediately and for 5 to 7 days after antibiotics are initiated. This will assist with the prevention and spread of pertussis while the patient is being treated. Since these patients are very ill, it will also be important to monitor both telemetry and pulse ox. These patients have a risk of developing respiratory distress and in some cases apnea. Therefore, it is vital to monitor the patient closely. The patient should also be encouraged to rest frequently, drink fluids, and eat small, frequent meals to ensure adequate nutrition. If the patient is not able to drink, IV fluids may be prescribed. Last, as a healthcare provider, it is important to provide both the parents and pediatric patients emotional support as well as education to prevent the continuous spread of pertussis. Some education that would be necessary for patients before discharge would be signs and symptoms of respiratory failure as well as dehydration, since both of these conditions can result in severe decompensation and death. A few differential diagnoses of pertussis in the pediatric population would be asthma, congenital heart defect, and tracheoesophageal fistula. Asthma is the first differential diagnosis that I would pick. Again, it would be important to get a full health history to see if the patient has a history of asthma and if the patient has been exposed to any triggers that may be related, such as smoke or coughing with activity. Congenital heart defect would be the next choice of differential diagnosis, especially in infants. Remember, one of the symptoms for infants with pertussis is cyanosis. Therefore, it would be important to see if the infant or child is experiencing any cough with vomiting afterwards. If there is a concern of a congenital heart defect, it would be important to get a chest x-ray or echo like previously discussed by Aaron and Nancy. Although we learned a few weeks ago most congenital heart defects are detected early in life, therefore it would be less probable for an older child, especially if the symptoms are now a new onset. The last differential diagnosis I will talk about, especially regarding infants, is the tracheoesophageal fistula. This is a congenital defect where the trachea and the esophagus are connected. This diagnosis is often identified quickly after birth, but if the fistula is small enough, it may not be identified right away. A tracheoesophageal fistula leads to coughing after eating as well as cyanosis. Again, it will be important to obtain a full past medical history and health history regarding when the coughing occurs. Has the coughing been present since birth or is it recent? There are many differential diagnoses, and I only listed a few, but it's important to remember that while you, as a practitioner, are going through differential diagnoses for another condition, it is also important to think of pertussis. The CDC reports that pertussis is often overlooked as a differential diagnosis. Last, I'm going to discuss health promotion regarding pertussis. Throughout the research, it has shown that being vaccinated with pertussis vaccine is the most effective avenue for disease prevention. Some barriers identified with the immunization of pertussis vaccine were noted to be healthcare access, personal decision, and knowledge deficits of medical professionals. It is especially important to educate new mothers regarding a booster Tdap vaccine before taking the new baby home to decrease the risk of the baby developing pertussis. Next, it is important that we as healthcare providers educate both the patients as well as their families regarding on how to decrease the spread of pertussis, such as covering coughs and sneezes, as well as discussing and demonstrating proper hand hygiene. It is also important to be aware that pertussis is noted to be a notifiable disease at the state level. Therefore, it is required that all healthcare providers report any confirmation of clinically diagnosed cases of pertussis to the appropriate authorities. Thank you for listening to my presentation, and I look forward to seeing your post.